Grateful that you're all here. Uh, Dr. Roth, take it away.
So, welcome everybody. My name is Alan Roth. I'm a practicing family doc and chair of family medicine at Jamaica Hospital in Queens, as well as vice chair of the board for primary care for all Americans. I'm excited to be here with everyone today. Joining us this evening with over 1,600 people from 40 states and growing, from the District of Columbia to California, as we were just talking about. We have over 350 zip codes with folks that have joined us. And the momentum is building and building, and we're doing really great things, looking for creating a movement that is for people, not for profit, that starts by providing a primary care physician for everyone, wherever they are in every American neighborhood, every American community. So thank you all so much for being with us tonight. It's really exciting for all of us, helping us to build this movement as we take care of a greater and greater part of this nation. So it is now my pleasure to introduce Dr. Fatima Khan, who is a former resident of mine when I was in my younger days, like last month. And I'd also like to thank the Primary Care for All American Zoom Committee, as well as John Wright, Patty Armstrong, and Liv Varade for organizing this wonderful event. So take it away, Fatima.
Hi, everyone. I'm Fatima Khan, an Integrative Medicine Fellow at Jamaica Hospital Medical Center in Jamaica, Queens, New York. I want to start by thanking you all for being here tonight. By joining us, you're helping to build a movement, one that focuses on providing healthcare to people in every neighborhood and community. Please add your name and location in the chat. As a quick reminder, we do not use professional titles here. This space is about working together and valuing the ideas and commitments that will drive this movement forward. Now, it is my great pleasure to introduce our keynote speaker, Dr. Andrew Saal. Dr. Andrew Saal joined the Pima County Health Department as the medical director in 2024. He's a fellow of the American Academy of Family Physicians and board certified in clinical informatics. Andrew served with the U.S. Indian Health Service on the Hopi Reservation for many years. Over the last 25 years, he has worked in community health centers across the United States. As the Chief Medical Officer of North Country Healthcare in Flagstaff, Arizona, he oversaw its growth from 3 to 13 clinical sites. As the Chief Medical Officer of the Providence Community Health Centers in Rhode Island, he led the agency's transformation into one of the highest quality community health centers in the nation. With a strong focus on population health, Andrew launched community health worker programs, clinical pharmacy services, and a residency for family nurse practitioners. He is currently an assistant clinical professor of medicine with the University of Arizona College of Medicine. His clinical interests include addressing healthcare disparities, empowering communities to care for themselves, and helping train the next generation of clinicians. Take it away, Andrew.
Thank you. And as they say, aw shucks, but my name is Andrew. Hi, y'all. And if you're ready, I'm going to try and share the correct mode of the screen here, and hopefully it is not presenter mode.
It is in presenter mode.
Okay, so hold on, let me launch this here. How about now? Still presenter mode?
Yeah, but a little better. And then the last one you went to.
And we'll swap it.
There it is. You're perfect.
Hooray! Well, good evening, everyone. My name is Andrew. A brief talk here. Michael and I have known each other for many, many years, and he said, hey, how would you like to join PC4AA? And years ago, I was one of those early members, and I still try to attend whenever I can. But our topic tonight is, if we really are going to have primary care for all Americans, let's talk about this very interesting, strange thing called community health centers. And yes, they do primary care. They also do community empowerment. And very importantly, we need your help to help them succeed. So with the blessings of a secret government plan, I actually have a map of the American healthcare system. This is what it looks like. And as you can tell, it delivers health or something like that. Part of what I do when I do teach in the School of Public Health, I like to point out that we have a very interesting, very American system. And the grand assumption, of course, is that, gee, if only everyone had health insurance, then things would get better, right? And right out of the gate, I have to point out that just because you have health insurance doesn't mean you have health. Just because you have health insurance doesn't mean you have access to health. And you know this because if you haven't tried to call lately to find a physician or a primary care nurse practitioner, there's a big problem here with primary care supply in the United States. And of course, having health insurance doesn't mean you can get equitable health. And one of the neat or peculiar flaws of the American healthcare system is if you don't know where your medical home is and you have a problem, the path of least resistance is to go to the emergency room. So I want to give a shout out to people who work in emergency medicine, but that has been the fail-safe and one of the great big symptoms for what can go wrong if you don't have adequate primary care. And of course, this is part of the phenomena. The more uninsured there are, they will go to the ER. The hospital will send them to collections or write it off, and then the hospital will tell Blue Cross or United that it costs more money to be seen. The commercial insurance then passes that charge on to you, the consumer, by raising your rates, which makes more uninsured people who then have to rely on emergency care instead of primary care. And so one of the great summaries of 50, 60 years of American healthcare, if you want to know why costs are going up, it's part of this vicious cycle. In the absence of really good primary care, people go to the ER. Now, in 2010, things were pretty bad. We were consuming 20% of the gross domestic product just doing healthcare, and we had nearly 50 million Americans who were uninsured. We made a bunch of changes over that decade, and we got it down to about 25 million Americans. And hey, that was a step in the right direction, part of that incremental growth towards making certain people had access to primary care. But remember, the assumption is if only we had insurance, we would have primary care. And I can go on that topic for hours, but not tonight. If you have been paying attention to the news lately, the price of insurance just went through the roof. They took away the subsidies, and now they're going to change the way Medicaid works so that you have to keep proving eligibility. But I do want to point out that for most middle-class working Americans, if you go to buy insurance on the exchange, you're now facing down $26,000 a year to insure a family of four. So it's really hard to do this if you need to pay rent or buy food. So paying attention to this, politics does impact this. And here is something rather neat. This is a very short email. So the Congressional Budget Office was asked, if we put in all the changes we want in H.R. 1 to give everybody a tax cut at the high end of the income bracket, will this affect insurance? And they came back and said, yes, we'll go back from 25 million back towards 50 million Americans. And my favorite part of this email from the nonpartisan office was, please let us know if you have any questions. And yes, that email really went to Congress and they still voted in H.R. 1. So we now greet the next decade with a new face of what being uninsured in America means. And that now means 1 in 5 of our neighbors. It means 1 in 8 of the children. And you have to stop and ask, if primary care and prevention are so important, how do we begin to approach taking care of 50 million Americans who cannot afford insurance? If only there was some bipartisan way where people could pay what they can, maybe build a little bit of insurance and work in the private sector. Surely there must be a bipartisan solution somewhere. And I'm happy to say that for the last almost 60 years, these things called community health centers have been doing what's called the sliding scale. And everyone goes, what's a sliding scale? So here's, when you hear about these community health centers, know that they do take Medicare and Medicaid. So if you've been trying to get on Medicare and you call and you're trying to find a medical home, often it might be one of these places. They do accept commercial insurance to help keep the lights on. But most importantly, the uninsured can go to a community health center and pay their fair share. And you can pay as you go. And that's called the sliding scale. And what's neat about this is if something is truly free, a lot of people will feel guilty about taking something that's free because surely someone else needs this. But if with a sliding scale, you pay what you can pay. And usually it's about 2 hours of minimum wage. So for 20 bucks, you might be able to go see a physician. You get the care you need, you pay for what you want, and you know what? The next time you need care, you can come back. So a big part of this is helping to create what's called a medical home so that uninsured people can get regular primary care. So that, of course, is the segue. What are these things called community health centers? They've been going strong for 60 years. And so in the next 5 or 10 minutes, I'm going to cover the history of how we got here, why it's really bipartisan. It is a federal grant. There's some strings attached. And most importantly, how you can help make a difference. So let me turn the clock back to 1964. It's Freedom Summer. And a young, absolute, wonderful troublemaker pediatrician from Boston named H. Jack Geiger joins up with the Medical Committee for Civil Rights, and he goes down to Mississippi. And while down there, he's helping protect the Freedom Riders, and he's looking at registering people to vote. But of course, like all good pediatricians, he did a needs assessment and realized what they really needed was primary care. This, of course, is the group. If you can see it, it's actually on the wall behind me here in the office. This is the Medical Committee for Civil Rights. They marched on Washington, D.C. in 1963. That's a group of physicians, an integrated group of physicians who really wanted to approach healthcare as a human right. So they founded the community health centers in the civil rights era, but out of the gate, they recognized if you don't address the social problems underlying health, you'll never be able to get ahead of things. And that includes hunger. It's really hard to treat diabetes if you can't afford fresh fruits and vegetables. It's really hard to treat asthma if you've got substandard housing. And of course, you need to create jobs, particularly in rural and urban communities. So they created the community health centers to create jobs and empower communities. And there's the other founder, Dr. John Hatch. And Hatch had this to say: if you really want to help improve the health of a community, you've got to break that cycle of poverty. And you do it by empowering people and get the community to take care of itself. Now let's jump ahead 60 years. They started these things called community health centers. Here's the philosophy. It's not what you do, it's how you do it. So of course, staying hard is healthy if you don't even know you have blood pressure. So if all of the screening for blood pressure is done in clinics, then only those who can access clinics will ever be screened for blood pressure. You begin to see the cycle here. It's hard to stay healthy when you can't access primary care, when you can't get to primary care, when there's no supermarket on the corner, or you can't get fruits or vegetables. If I, as a physician, tell you to go for a walk 3 times a week, and it's really hard to do if it's not safe to walk outside. Or worse yet, if you have to choose between paying for rent or buying your medicine, or if there's interpersonal violence. So that philosophy of how they practice is really wonderful. I really like it. They recognize that primary care is foundational, and you have to greet the person where they are and empower them to take charge of themselves. Now multiply this over 60 years and add this up in all 50 states. And what you realize is that these community health centers have evolved wonderfully differently in every community. And the old joke goes like this: if you've seen one community health center, guess what? You've only seen one community health center. I've been coast to coast in the country. I've worked in dozens of these and consulted in dozens of others. They are all wonderfully unique. But here's kind of the net sum. There are now 350 million Americans. 32 million Americans get their primary care in these things called community health centers. And the people who go there, 90% are coming in with household incomes under $50,000. So if you're fixed income, or if you're the wealthiest person in the world, you're going to be welcomed at a community health center, because what's happening is they shift the costs from those with insurance to those without. That's part of the sliding scale and how the math works. But right now, 1 in 8 children in the country are getting care in these primary health care centers. Notice 20% of rural Americans, 1 in 5, and also a strong prevalence among geriatric and people over 65, 1 in 15. So here's how you find them, because they all have different names. Of course, it's basically findahealthcenter.hrsa, and HRSA is HRSA. That's the branch of the federal government that does this. Findahealthcenter.hrsa.gov. Pop that in your browser and plug in your zip code, and what you'll find is your neighborhood. Because right now there's 1,400 FQHCs, community health centers, around the country, 16,000 clinics, 32 million people call these places their medical homes. And you can zoom in wherever you are in the country. You can see there's a ton all over New England. You probably have a community health center in your town. It may have an interesting name. You won't know unless you go to findahealthcenter.hrsa.gov and start looking. Here in my corner of the nation, just a few here in the great state of Arizona. We have 24 community health centers with over 100 neighborhood and rural clinics around the state. And down here in the southern corner of Tucson, where I'm at, 12% of the local population, including 12% statewide, are getting care in these things called community health centers. And remember, this is hopefully comprehensive primary care, because everyone deserves high quality care and do it with dignity, whether in Woonsocket, Rhode Island, or here in Tucson. I mentioned before it was bipartisan. Here's the easiest way to understand that. If I gave you an insurance card and said, good luck, and you don't have a medical home, basically, if you try and go into the healthcare sector and you don't have primary care, you are that column on the right. And this is almost 20-year-old data. What you see is that if you don't have that medical home, you kind of access the ER now and then, you kind of go here, you kind of go there. It's not coordinated. But having a primary care clinician coordinates your care. Having a medical home is the place you know where you go. And look at that left column, very, very significant savings. So this is a great financial argument for why primary care for all Americans works. It's higher quality, and you know what? It's cheaper, and people like it. So who likes these things? Well, here is, I think, President number 43. George W. Bush was a huge advocate of community health centers. His argument as the governor of Texas was, if I don't do something to get the uninsured people somewhere else to go and give them a medical home, they'll keep going to the ER and the rural hospitals will go out of business. So if you want to save a hospital and you hear about they're on the ropes, you have to look at how many people without insurance are going there and think about building more primary care. Meanwhile, President 44 had this to say: it isn't just about promoting wellness, it's about prevention, because a healthy economy needs a healthy workforce. And that is a bipartisan issue we can really get behind. We need healthy primary care to keep the entire working class and upper class and lower class and retirees. It helps keep the community healthy. Do the community health centers work? Well, here is that nonpartisan Office of the Congressional Budget Management, perhaps the most cost-effective of all federal programs. And that is breathtaking when you stop to think about it, because there is a federal grant. And you, as taxpayers and consumers and citizens, need to know this, because we need your help. So here's the big picture about that federal grant. The community health centers do get a small federal grant. It's often 5, 10, 20% of their operating budget. When they do that, it allows them to operate at a loss while caring for the uninsured, while promoting that sliding scale. So they're going to use it as seed money. Meanwhile, they're going to take Medicare and Medicaid and traditional insurances to keep the lights on. And if this begins to sound like something familiar, this was actually a Republican idea that was the counter proposal to when Hillary Clinton was an advisor for Bill Clinton. And the idea basically was a pinch of federal money operating in the private sector. This goes on to become kind of what we saw with Romney Care in Massachusetts. But the idea is you can create this bipartisan thing that is maybe insurance centered, but it's a pinch of federal money, private sector rules, and trust innovation. And this is always the best part. You've got mission-driven, nonprofit, innovative, community, locally owned places. And if they do a really good job, they can serve more people. And that's great, because I said there's a federal grant, but here is the real difference. It turns out community health centers are nonprofit 501c3s. When everyone immediately says, wait a second, aren't the hospitals also 501c3 nonprofits? Some of them are, and some are for-profit, by the way. But there is a very distinct difference. Just because the IRS says somebody's nonprofit doesn't necessarily mean they behave the same way. So I'll stop here. I can't see you because I'm looking at the camera at the moment. But think for yourself, Who sits on the board of directors at that local hospital that you know? So think about the kind of people that are on that board of directors. And I bet a lot of you will go, oh, I bet there's doctors, there's lawyers, there's realtors, there's bankers, there's people who can donate a building, right? Right. Do you think they let the janitor on that board of directors? Probably not. But when you hear that there's a community health center in your neighborhood, you have to stop and say, wait, who's on the board? And right back in 1964, when they wrote the legislation that authorized them, Jack Geiger put in some very specific language. Remember, he wanted the neighborhood to be empowered. And here it is. Every community health center has a board of directors where over half are required to be patients. Hard stop. Let that soak in. Over half the board must be patients of the clinic. And I want you to imagine if ExxonMobil had a community board where half the people worked in gas stations or lived just downstream from where they were drilling. That would be a very, very different organization. So community boards help keep community health centers rooted in their community. They're community centered. They are community responsive. And that, I believe, is why they make a difference. So, of course, here is how you can help. So remember, over half of whom are required to be patients on the board. Step one, find them. They are probably in your neighborhood, and do that by going to findahealthcenter.hrsa.gov, and then find their websites and start looking. And look for the mission statements, look for the programs, look for what makes that health center different. Do they address the needs of your community? Learn more about the sliding scale. Maybe you don't need it, but someone you know just might. So as we face down another 25 million Americans losing health insurance in the coming 15 to 18 months, spread the word that there is primary care out there, that it's affordable, and you can pay as you go. I want you to find neighbors who may be a patient of that community health center and ask them how it's going. Or better yet, if you find one that you click with, become a patient of that community health center. They need your business. If you are blessed with a nice commercial insurance, they will take those nickels. Trust me, they need it. They're using it to offset the care for the uninsured. And of course, then comes governance. If you find a community health center you like, see if they have a community advisory group, because they often will stop and listen. They do community health needs assessments. They have listening sessions. They say, who are we? What do we want? What can we do better? And you go to these things and you listen, make certain you're all on the same page, and then you advise. And if you are in a community where this is going on and you've got that organization and you're proud of them, this is when you say, hey, how do I become a board member? Because the best part about community health centers is that you too can get on the board and help make a difference in your community. So I just want to point out that community health center governance begins with you. So know that they're out there. So let me wrap up here and we'll take some questions. Remember, when you hear this, just because they get a federal grant does not mean they're a federal agency. They are locally operated with local boards of people like you and me. They are so nonprofit, it's wonderful, but over half the board must be patients. Uninsured patients are welcome. They will take any insurance you got. Philosophically, you're going to find that they are just absolutely obsessed with reducing health disparities. That means whether you're young, old, or whatever faith or creed, you should have the same health outcomes as your neighbor. They're going to be talking about the social drivers of health, food and housing. They'll often talk about workforce development. And as we heard last month on the session, they even do medical education and they will try to create residencies. So this was the topic last month. So a community health center not only wants to create jobs, they want to train the next generation. So with that, I will just wrap up saying, hey, that's a mission statement from a community health center there. And notice how the rhythm goes. High quality, it's extraordinary care for everyone, regardless of the ability to pay. And that's how you know you're in a community health center. With that, I'm going to stop talking and we'll take some questions.
Well, thank you so much, Andrew. That was very fascinating. As we let people add questions into the chat, just to make sure you guys know how the chat feature works, I would love to have everyone drop in. What is the name of your local community health center? You might know it offhand. I know mine. It's Health First in Fall River. We get to do some work with them with the company that I work with, but I'd love people to drop into the chat if you actually know the name of your local community health center. But I think, Andrew, my first question for you was, how do we help? How do we make that difference and you did such a great job of outlining it, starting with this Find a Health Center, hrsa.gov. But as patients, right, we all receive care. How can we be, looking at that? I would feel very guilty taking a spot from someone else. So can you talk us through that just a little bit?
Yeah. And granted, in not having enough primary care capacity, sometimes you run into a health center that may be putting people on a waiting list. But generally, as I've been around the country, different sizes, different shapes, commercially insured people are welcome because the revenue they make there helps offset the loss. If your entire payer mix is 100% uninsured, they'll go out of business very, very quickly. So just know that if you are blessed with Medicare or commercial insurance, usually you are going to be welcome in that health center. It helps balance the bills.
I mean, that absolutely makes sense. So for these different community health centers, how can communities help them focus on providing primary care, encourage them to become teaching areas, right? There's so much education that has to happen around, these individuals, as you talked about, the dynamics of health, right? Creating healthy communities around them, making sure they have access to healthy food, and the importance of that. How do we build that out with them in partnership, that education piece?
Well, to steal a concept here, there's nothing really unique about MAHA. Okay, it is nutrition and food. So I'm going to steal that back. Community health centers have been talking about that for 60 years. We need to focus on the structural drivers, the built community. We need to look at communities that are safe, where you can go for a walk, that have food banks and food markets and farmers markets and access to all these things. So some of the most successful community health centers I've seen, they're not looking and hiding behind the four walls. They are out in the community trying to change the game. Not all do that, but some do. And you'll know a good one because they're very active in the community, doing some very, very extraordinary things. Part of the innovation that you find in community health centers is that. I forget where your question was going immediately, but as you can tell, I get excited about not necessarily the person right in front of me. They're the most important patient I'll see in that moment, but I'm worried about the upstream effects. I'm worried about the family at large and the neighborhoods, because if we don't address and prevent chronic diseases, we have to mop up chronic diseases. And it's much, much cheaper to vaccinate kids and promote breastfeeding and talk about healthy food choices than it is to treat all the complications 30 and 50 years later.
Absolutely. And I totally align to that with the health center that I am most intimately involved with. They're actually hosting a green market in their parking lot. So it's helping to pull people in and just make them comfortable with the building and all of those things. I think that's super important. We have Santiago.
Yeah. We'll do Santiago next. You just reminded me, one of my colleagues in Washington, D.C., their community health center addressed not one, not two, but 3 deserts. Okay, I'm in the Sonoran Desert, but they're talking pharmacy deserts because the inner city neighborhoods didn't have a pharmacy, so they built one in their clinics. They addressed food deserts by bringing a supermarket to be on their campus, and they addressed an economic desert by bringing a credit union there to do microloans in their neighborhood. Now that is a cutting edge community health center A lot of them are stuck in reactionary mode of just trying to put the fires out that are there. But when you look to the outside and address the upstream things, that's what's neat about this. Santiago, I think you're next.
Yeah, I put it in the chat, but let me just ask you, how do you deal with the fact that so much healthcare involves specialists?
First thing I do is I get involved in medical education and try and brainwash the next generation that primary care is important. Granted, it's upstream because debt load coming out of med school, you don't want to be a primary care doctor. They don't pay very much. But within the community health centers, we would often do this. We would hire specialists to come work in the community health center. So every Tuesday, we knew that a nephrologist wanted to come and see our patients, and that's when we'd run the uninsured patients through there. We also had asthma, allergy, nephrology, I've lost track, podiatry, but the specialists would come on campus because we were running a medical home. Now, why would a for-profit specialist come to us? Well, because they hate insurance, they hate bills, and dealing with uninsured is hard. So we'd basically pay them X dollars for every half day. You come to the clinic, I will fill your schedule, just document, and we'll call it even. And so they liked that a lot because it gave them a leg up on who's sick before they got sick. But more importantly, they could do really, really good care and not have the billing headaches of working in the fee-for-service system. So Santiago, I look upon this as a collaboration, but remember the root cause. If you don't have a medical home, if you don't have a conductor for the orchestra, care is fragmented and people will go where they think they need to go, and it's not often cost effective and it doesn't bring good care.
I think Ben put into the chat, but I would love to have you come on. Sorry, I called you Ben and you are Benjamin on there. I am so sorry. I'm a nickname person. But I'd love to have you ask this question because I think it really points to sort of this balance that we have to find within the community of moving from nonprofit to for-profit, making sure our books are balanced, not going under. Go ahead, Ben.
Thanks, Megan. I'm actually somewhere in the middle. Usually go by Benji, as the name here is Benjamin. So you're almost there with the nickname. Thanks for the talk, Andrew. I'm curious with the idea that I find very interesting of hoping you can get a net positive with some folks who will be coming to community health centers, getting reimbursements via commercial insurance. Is there any more granular data that's been collected about how that actually pans out across states, different health centers, the way that they organize the centers, whether they have more specialists, et cetera, to see if there's some are sustainable within the landscape of community health centers?
Right. And Benji, you asked a very erudite question. 50 states, 50 sets of innovation, and there's a ton of data here. Let me start by saying fee for service, what we've been doing since World War II, is part of the problem. So fee for service means we have to widgetize everything. We're going to bill in incremental units. And you know what? That may be great if you're a cardiologist putting in balloon stents. It backfires in primary care. So community health centers have been on the front edge in some states of doing cost-based reimbursement or value-based care, or sometimes called ACOs. So you'll find that community health centers are often part of Medicare ACOs or Medicaid ACOs. Look to Massachusetts, previously Rhode Island, and there's some other states where the community health centers actually were doing very well by taking primary care and saying, we're going to do this based upon the number of people you take care of. You keep them healthy, you keep them out of the ER, that's part of your margin. Now, with sparing everyone the lectures I love to give at the School of Public Health and Medical Economics, that doesn't mean an ACO is perfect for everybody. I suspect a more ideal situation for America is to take primary care and put it into a model where it's population-based and neighborhood-based, where people like know where their medical home is. And there's still a role for people who want to go into specialties and get, those special procedures, and those can be billed a different way in fee for service. So look for hybrid models, but I do want everyone to consider looking at what the Mass League is doing. They are willing to gamble and say, we can keep this population healthy. And they really, really fun things, such as focus on prevention, keep people out of the ER. Let's talk about food access. Let's talk about transportation to the clinics. So again, 50 states, 50 innovative solutions. Some states are further ahead than others. And I really hate fee-for-service for primary care. That's my opinion. I'm sticking with it.
Thank you, Andrew. We have two other great questions in the chat. I don't know what we have time for, so maybe we can do them quick back to back. So Pat brought up, how often do we see dental, mental health services all sort of under one roof, maybe not all in the same house, but all working collaboratively in some of these places?
Ask that again. I was answering a chat.
Absolutely. And I will try to do it as eloquently the second time. No, so as we look at some of these health centers, are we looking at them? How often do they integrate under the same roof dental and mental health or other similar services, maybe not under the same house, meaning they might not all report up to the same board necessarily, but can you talk to that a little bit?
Actually, a lot of them do. So the three broad spheres of what the FQHCs, community health centers, do. One is primary care. You'll often see dental and you'll often see behavioral health. So there's three kind of core businesses that can go on under one thing. The best example of this is called integrated behavioral health, IBH. If you try and get somebody in to see a psychiatrist, it's going to be a 6-month wait. And then you got to fill out the forms and you can't. But if you actually put the counselors directly in the clinics, they do something very neat. It's like, let's talk about how you feel about your diabetes. Maybe you don't need a pill for your depression. Maybe you're stressed out. And they do this very focused stress management counseling style. So it's not traditional, but when you embed them in primary care, integrated behavioral health clinics, they're actually save money. They reduce the amount of medications that people take. They reduce the number of ER visits people need, and they reduce the total cost of care. So I'm a mammoth fan of bringing primary care centered behavioral health directly into the clinics. And dental, don't forget that for some strange reason in America and Western civilization, we think that the mouth operates completely independently of the body. Go figure. But you'll find that community health centers do a lot of dentistry. It may not be cosmetic. It might be restorative. It might be focused on fluoride and varnishing for the kids to prevent caries. But some of them have basic dental care and some have very, very advanced dental care. The Holy Grail, if you find one that's doing dentures, let me know. It's a very risky business proposition for them, but generally they tend to focus on the preventative side. So again, yes, they do dental, mental, and primary care. And you'll find different recipes in different health centers. Remember, there's 1,400 of them across the country. They're all doing it differently.
Absolutely. And the one that I know, and again, that's, you only know the one you know, right? Also covers WIC, which is the, prenatal, postnatal care, which sort of leads into Catherine's question in some regards where, people who are in critical need of care also are potentially in immigration transition. And so how do these places deal with patient and data protection as federal policies are changing? I know I'm on calls with Massachusetts State often and how they're addressing them on a local level, but have you seen something that's really come out to support across the board?
They will operate very delicately. You don't want to be too overt. It is a very scary political climate. But for 60 years, they have worked with new Americans and Americans, regardless of where they were born and regardless of economic status. Until recently, clinics were a protected environment. There were 3 places that immigration was not allowed to go under the original rules: courthouses, churches, and clinics and schools and other places. You don't want people to be afraid to go to the police. You don't want people to be afraid to go to church. You don't want people to be afraid to go to the school to pick their kids up. And you don't want them to be afraid to get health care. Those rules changed in 2025. So now there is a federal law. It's called HIPAA. And people should get very excited. Doctors usually pull their hair out when we say HIPAA. HIPAA is Health Information Protection. And you know what? The rules of HIPAA have been set in stone for so long. They basically say that parts of the clinic are off limits. You cannot get in the back behind the locked door in order to protect patient information. And so I can neither confirm nor deny that a lot of community health centers have done training programs. You can't see what the card says, but it basically guides the staff in what to do should somebody walk in the office waving a warrant. And basically it's respectfully stall, explain that it needs to be a specific kind of warrant, and let me get my boss on the phone. And meanwhile, what goes on behind the locked door is protected health information, like you, like me, and like everyone else. No one has the right to access your health information unless you give permission. So the community health centers have risen to the response of immigration by resorting to the original rules protecting health information. And that's all the more I can say on a recorded call, but I've seen different interpretations of those rules across all the states. Basically,
Absolutely.
we care, and we want you to know that you can get care in our shop.
Absolutely. And I'm sure that there are many resources for that. If you are interested in pursuing further, please always feel free to reach out to the PC4AA team through the website. Speaking of PC4AA and the website and everything that has come out of this great group, Michael Fine, do you want to take us away for the evening? You might have to come off mute first, because we do want to hear what you have to say.
Yeah. Okay, that's better. Thank you, Patty. And thanks, Andrew. I knew you were good, but I didn't quite know you were that good. That was spectacular. And I say that as a patient of a community health center now for about 10 years, and also as a member of a local work group that meets in the community health center once a month. And that after doing that for a number of years, nominated one of our members to join the board of that community health center. And so now the Situate Health Alliance has a representative on the board of Well One, the community health center where I am a patient. Pretty spectacular. That said, I just want to remind everybody that the primary care crisis is actually worldwide. I'm just back from Europe, where, to my surprise, I heard that the EU is short about 500,000 clinicians, and like us, is struggling to train enough clinicians to care for everyone, although they are far ahead of us because most places in the EU have for years been providing primary care to everyone. I was in Lithuania, where their public health outcomes are just about either about what ours are or much better. Their infant mortality rate is like a half to a quarter of what ours is. But in Lithuania, they pay $4,200 per person per year for healthcare. The United States, we pay about $16,000 per person per year for healthcare. Even so, the shortage of clinicians is a worldwide problem, one that took 40 years to make. We've just heard how community health centers are part of the solution because they open their doors to everyone. But community health centers also struggle with workload and workforce and resources. So now our challenge is to help those health centers do more than open their doors, and to help them reach out to everyone in every neighborhood and community, to everyone who doesn't yet have a robust primary care relationship. And that's where our communities and states come in. Our opportunity is to help communities support their health centers and help states step up and fund teaching health centers, and then also to measure and report how effective health centers are in providing primary care to everyone in their communities and not just the people who already walk through their doors. That's an opportunity for our local work groups to include community health centers in their local work group as they do their work and report data about primary care attachment and how many people in each community actually have and use primary care. There's also an opportunity, as I said, for local work groups to get their members on health center boards and help them see the people they haven't seen yet so we can get primary care to everyone. So you know the drill. Join a local work group if there's one in your community. Start a local work group or state work group if your community or state doesn't have one yet. That's how we'll fix this mess, one community and one state at a time. So, Earth to Texas, Earth to Illinois, Earth to Maine, and Earth to Nebraska, and yes, Earth to Arizona. Let's all roll up our sleeves and fix this mess together. Now I'd like to reintroduce Alan Roth, who'll talk about how you can support primary care for all Americans through donations and through volunteering.
Thank you, Michael. So we all know, we heard today that, primary care is the foundation of a strong healthcare system. Yet we know that millions of people still are struggling to access high quality care, affordable care, get appointments, get the care they need. And we all at Primary Care for All Americans are building a national grassroots movement to change that. We are a small volunteer-driven organization, and your support helps us host events like this, produce our newsletter, and expand our local work groups, like Michael has said, all across our country. If you are able, please visit our website, primarycareforallamericans.org, and click donate. Every contribution helps. Every little one, every big one, they all help. You can also sponsor a scholarship for a student or a community member to attend our convening meetings, to join our local and state work groups, and do other things with us. A gift of $250 will make that possible to help students join our organization and participate. So thank you to the next generation of primary care leaders, and thank you all for joining us and being part of this movement. Fatima, take over.
Thank you all for joining us tonight. Our next meeting will be on September 15th. So enjoy the summer break. We encourage everyone to invite someone new to get involved in our movement. You can register on our website at primarycareforallamericans.org, where you can also check out our local and state playbooks, volunteer, and donate to support our cause. Thank you again to Andrew, our facilitators, and to everyone present for joining us tonight. Have a great evening.